Hi, this is a brief introduction to electronic fetal monitoring. It is intended for students of Nursing 135 at St. Francis School of Nursing in Trenton, New Jersey. It's not really intended to be a comprehensive course in fetal monitoring, but it will familiarize you with the terminology that we use. You'll be able to see the basic fetal heart patterns, learn what's considered reassuring and what's considered abnormal, and we'll talk about uterine activity and how to interpret some of the patterns that you'll see in antepartum and in labor and delivery. And the first thing that we can discuss is the concept of external monitoring versus internal monitoring. And in the picture here, you see the external fetal monitors applied. And let me see if I can point out. This here is the tocodynamometer that measures contractions, uterine contractions externally, and that is an ultrasound transducer, and that measures the fetal heart rate externally through the use of ultrasound technology. And you're not really actually hearing the heartbeat so much as what you're hearing is a signal that's transmitted when the ultrasound finds a moving object. And so that is what external fetal monitoring is. And that's the most common type that you're going to see because it's less invasive. In order to do internal monitoring, and we'll talk about that in just a second, you have to rupture membranes and you have to basically go inside the uterus. The scalp electrode goes into the baby's head, just as the name suggests, and the internal uterine pressure catheter goes into the uterus to measure the pressure. So we'll see external monitoring much more frequently, but in cases where we need to be really precise, you will see the use of internal monitors. And as I said, the downside with the external monitoring is that it is less precise. It's easier to pick up a maternal heart rate signal, and you can get some signal ambiguity. And with contractions, you can measure the frequency and the duration of the contraction, but you cannot measure how intense it is. And we'll talk about that a little bit more. But that is an external monitor. Moving on to internal fetal monitoring, I have a picture down in the bottom right corner. This gives you the most precise measurements. When you put this electrode, there's like a little corkscrew on the end of it. I have a picture of that as well, which I'll put up in a second. And it kind of screws into the baby's scalp. It shouldn't go into a fontanelle. It should go elsewhere, so you kind of have to palpate where you are. And that will read the baby's heart rate, almost like an ECG. So you don't worry as much about signal ambiguity. If you're using internal monitoring and the equipment is functioning correctly, you are getting the true fetal heart rate. You can visualize the periodic changes really well. You can get a good look at variability, and you don't worry about loss of contact. Now, the intrauterine pressure catheter goes in through the cervix, and this one is sort of up over the baby's head. Here, let me point that out for you. But this is inserted by a licensed independent provider. You would not, as a staff nurse, insert this. You would be responsible for assisting with the insertion of this, and you would zero the equipment so that it read correctly. The advantage of an intrauterine pressure catheter, and there are two big ones, is that you measure the contractions precisely. So if you have a mom who's morbidly obese and it's hard to measure contractions, you have the advantage of being able to measure them from the inside now. You can see exactly how long they are. You're not just catching maybe the peak. And you can correspond, especially if you have internal heart monitoring as well, you can really see sort of where a contraction is in relation to maybe some changes in the fetal hearts, which will become important when we discuss that later on. The other main advantage to having an intrauterine pressure catheter, is that many of them have the capability of being hooked up to what's called an amnio infusion. So that might be another reason that you see these in the clinical setting. But what is really good is that you can measure the intensity of contractions with the IUPC, which you cannot do with an external monitor. You can only estimate that by palpation. So, and we'll talk about that a little more when we get some strips up here to look at. Obviously, this is a more invasive technology. I want you to see, let's see if I can find pictures of those devices. Here's one. put that down. That's the IUPC. And that's what gets sort of snaked through the cervix and either up under the baby's head, or in that picture it's up over the baby's head. And you can see where that, that's invasive. It goes right into the uterus. So it really needs to be inserted by a licensed independent provider under sterile technique. Let me just show you real quick that port I was talking about. See that little port right there, right there. That is where you would hook up an amnio infusion. So it's just like one more advantage to having that. But it is invasive. And of course, you have to have ruptured membranes. And as we know, the membranes sort of protect the amniotic sac from any kind of infection. So that's important. The scalp electrode, and I don't see a picture of that here, so I will find one and put it up. Give me 1 minute. Okay, there it is. And let me just show you that little arrow. Here it is. That's what gets screwed into the baby's scalp. This plastic tube here gets withdrawn. It's just sort of a guide so that you can get that wire and that electrode in, and then you kind of screw in the wire and the stylet comes out, that little plastic tube comes out. And in most cases we have the LIP put them in. I think there are some states, particularly those that are in rural areas, that allow staff nurses to insert the ISA. But again, you have that risk of infection. You're going into directly into the baby's head, and there's the picture of that. Now the great thing about that is, as I said, you are doing like exactly the beat-to-beat calculations, so you see everything really well. However, if mom has herpes or HIV or any other infection that could ascend and really hurt that baby, we're not going to use this. The other big drawback, and I know that I have seen literature that says that one of the advantages is that mom gets more mobility because there's less loss of contact, but I really don't know too many people who are comfortable letting mom walk around. It's very easy to dislodge these devices. You do secure them to the leg. However, I feel really uncomfortable letting people just kind of get up and walk around, and so do most of the people that I work with. You work in a different hospital, you might have different policies and procedures that guide you, but even with internal monitoring, if you want that woman to really be active and walk around, you have to take great care not to let any of this stuff get dislodged. So that is internal fetal monitoring. Okay, so we're going to talk about the basics of reading a fetal monitoring strip. It's nothing fancy. It's just basic material. And I have here like a little strip down the bottom, which I can change, alter to make look like what I want. And right here, it looks like a fairly normal strip. So I'm going to give you the parts of it. Down here at the bottom, this is our uterine activity. These little humps are contractions. Up here at the top, that's our fetal heart rate. And it reads out in beats per minute. Okay, these big red lines, okay, from one to the other is a full minute. So each one of these little boxes is worth about 10 seconds. Now going up here on the fetal heart rate are multiples of 10 in beats per minute. So 30, 40, 50, 60, 70, 80, 90, 100, 110, 120. You get the point. And so that's sort of where we read the beats per minute. Down here, if we have an internal uterine pressure catheter, an IUPC, we can read the intensity in millimeters of mercury. However, most of the time, you're going to be reading your intensity by putting your hands on mom's belly and palpating the strength of the contractions, and we will talk about that sort of as an addendum to this. Okay, but that is really the mechanics of that. And so when you read a strip, we can start by reading contractions. Actually, most of us, when we go into a room, the first thing we eyeball is baby, make sure baby's okay, and I just take a rough glance at it. But then, when I'm starting to chart, I go to my contractions. Okay, so I look. And remember what we said, this is an external monitor. We can measure the frequency and the duration, but really not the intensity, so let's start there. We start measuring the frequency from the beginning of one contraction to the beginning of the next. So let's go 1, 2, 3, 4. We have contractions that are 4 minutes apart, assuming that this is a pattern that's consistent, which many of them are not. But right here for this part of the strip, it looks like they're 4 minutes apart. We can count the duration. These little boxes, remember, are 10 seconds each. 1, 2, 3, 4, 5, 50 seconds. Here they are, 1, it's a little hard with the logo, 2, 3, 4, 5. So we have contractions that are 4 minutes apart, 50 seconds each. And I'm going to let that strip run just so you see what it looks like. Now we mentioned that we read the fetal heart baseline at 140, and the way we do that, again, is that we're looking at the average beats per minute. So, and we're hoping that somewhere between 110 and 160. Okay, if it's below 110, we have bradycardia. Sorry. Typing and talking at the same time. If it's above 160, we have fetal tachycardia. Now that's the baseline. We have changes, periodic changes like accelerations and decelerations that will sometimes bring the baseline above or below those numbers. But if it's the baseline that we're talking about here. If the baseline is between 110 and 160, even if you have accels that go up to 180 or you have decels that go down to 90, you are still in a normal baseline range. Okay. Next, we look at variability. And let me see if I can get our strip to cooperate. Okay, so now we have, we had our moderate variability over here. Now we have absent variability. So let's talk about what variability is. And variability is the fluctuation within the baseline. And what we want is good moderate variability. It gives us a nice responsive baby. But what we have right here is absent variability, and that is not a good sign. Oh my goodness. Okay, so we have absent variability here, and this is no detectable fluctuation. Within the baseline. Okay, and what this is usually a baby who has been deprived of oxygen for so long that it no longer responds. It's like those people whose blood sugar goes up and down so much that they no longer feel the symptoms when they're high or low. So this baby no longer is responding to the hypoxic insult. Sometimes you'll see this with a baby who has central nervous system impairment. For example, you have anencephalic babies, or you have some babies with different brain abnormalities. But this would be a case where you would want to try and resuscitate this baby in utero if there was, if you were concerned, and you should be. So that is absent variability. And variability, by the way, is probably one of the best indicators on a strip of what your baby's doing on the inside. Okay, so here we have minimal variability. And this is a baby that has 1 to 5 beats per minute fluctuation within the baseline. Okay, so the baby's responding, but not a lot. Now, this is also not a reassuring sign. However, there are some normal things that happen that make babies have minimal variability. One of them is fetal sleep. And babies can have sleep cycles just like they have cycles. Fetuses have sleep cycles just like newborns have sleep cycles. They're not terribly long. We talk about maybe 40 minutes at a pop. So if you're looking at 40 minutes or more of this strip, you want to do something to wake this baby up. If they've been reactive before and they have a half an hour of this, you're not maybe sitting on the edge of your seat, but you don't want to look at it forever. So fetal sleep could cause this pattern. Maternal medications, particularly NARCs and MAG, can cause this pattern also. So if you've just given mom some narcotic pain medicine and she has this minimal variability, you expect it. And as the pain medicine wears off, the baby will start to look a little more lively. But just like mom is sleepy, baby's sleepy. Magnesium sulfate knocks baby out just like it knocks mom out. And in fact, that's one of the reasons that if you have a delivery and you know that you have either narcotics or magnesium sulfate on board, you need to let the neonatologist know. And so those are things that can cause minimal variability. Now, if you can't account for this minimal variability by any of these things, it's been too long for it to be fetal sleep, and you never medicated mom, you need to do something to make this baby a little bit happier in utero. And we'll talk about intrauterine resuscitation measures at the end of this, but we're going to get through variability first. So we're back to my favorite, moderate variability, which is 6 to 25 beats per minute fluctuation within the baseline. Sometimes a minimal can look like the low end of moderate, sometimes a marked can look like the high end of moderate. But generally speaking, when I look at this, just my eyeballs are happy. I know that I have a baby who's well oxygenated and who's responding to its environment. The sympathetic nervous system is responding to the needs for oxygen. It's sensitive to all the little fluctuations because it's used to having oxygen, so it responds. So this is a baby that has a little bit of reserve. I'm hoping that it's going to tolerate labor like this for a good length of time. Moderate variability is one of the most reassuring things you can have. If you have moderate variability, you can tolerate some of the other changes a little bit more. Even your decels. You certainly respond to them, you're certainly going to look at them and interpret them, but moderate variability is one of those things that says right now, at this moment in time, this baby is still responding to the need for oxygen by changing its heart rate from 1 second to the next. Okay, now this last pattern is called marked variability. It used to be called a saltatory pattern, but I haven't seen anybody referred to it in a long period of time, and this is greater than 25, oops, sorry, I wrote 35, but I meant 25 beats per minute fluctuation. Okay, and marked variability is a baby who maybe was well oxygenated, but is now experiencing a lot of stress and trying to maintain a baseline and struggling to do that. And so some of the patterns that can cause marked variability include cord prolapse, cord compression. Usually you'll see variables, but if you're seeing a cord that's maybe only partially compressed, it's like a sudden insult will cause this pattern. Any kind of, it says maternal hypotension, and I typically don't see this pattern with your epidural plunges or anything like that. But if you have any sort of sudden insult, you might get this marked variability. It's not a really common pattern, but when you see it, pay attention, because this is a baby who's under stress and they're going to lose their reserve soon if you don't act. Okay, so that is your marked variability. And then the last pattern within variability that we're going to talk about is sinusoidal. And this is typically what sinusoidal looks like. It's this, let's see if we can make that a little bit bigger, this very even sawtooth pattern. I mean, I know it flattens out a little bit like right here, but for the most part, it's going to look like this. And when you see it on a real strip, and I have seen it, it's a very, like an undulating pattern. It is very even and smooth. It doesn't have a lot of those jagged edges. This is a pretty ominous pattern, I'm going to say, and what you usually see it with is fetal anemia. I want you to note also this contraction pattern right here. That is called tachysystole, or uterine hyperstimulation, which is 1, 2, 3, 4, 5, 6, 7, more than 5 contractions in a 10-minute period. Here we have 7. And you'll see that these intervals between the contractions, there isn't one really. And this is a common pattern when you have either placental abruption or uterine rupture. And so what you're having is this massive bleeding. Either there's a big hole in the uterus, which is a topic we'll cover later, or the placenta is shearing off. And two things are happening. The uterus is trying to save mom's life by clamping down, and the baby is showing signs of fetal anemia. That's what fetal anemia looks like. It looks like a sinusoidal pattern. And so we really want to assess what's going on here. We got to get our hands on the belly. Mom's usually in a lot of pain at this point. If she has an epidural and she ruptures or abrupts, we might have a masking of symptoms. So if you see this pattern, you need to respond to it. And typically what's going to happen is you're going to need surgical resolution of this very quickly. But that's a sinusoidal pattern. Shrink that down. I'm going to put that on here with tachysystole. No, it doesn't want to give me that. Okay. Sinusoidal, remember, is fetal anemia. And the tachysystole, greater than 5 contractions, 10 minutes. And that has to kind of be over like a 30-minute average. But when you see that, you know you have a problem. And that tachysystole happens a lot with your hemorrhagic disorders and your uterine rupture. So this, to me, looks like bleeding. Hemorrhage that's affecting mom and baby. Okay. You don't really have to memorize that, but that is one of the other patterns of variability that you can see in a fetal heart tracing. Okay, well, I'm glad we got rid of that strip. It was pretty ugly. Now we're going back to a nice normal strip. And if you remember what I told you in antepartum, this is what we would look for as a reactive non-stress test. Now, it's very reassuring. We have these accelerations of the fetal heart rate. Accelerations are one of the changes from baseline. And they are indicative of fetal well-being. They tell us that not only can this baby respond to those little second-to-second changes, but they can respond to things like fetal movement. That they can respond to the demand for increased oxygen. So we have an intact nervous system, and we have a well-oxygenated fetus. So you can think of, accels. Think of accels together with O for oxygen. That's just like a sneak peek. I'm going to give you a little cheat sheet for remembering what all these little periodic changes mean. But a moderate strip that has moderate variability with accelerations and contractions that are spaced adequately. This is a good strip. This is a day I'm going to have breakfast. I'm going to get my coffee. I can sort of relax and take care of this patient. Worry more about making sure mom's comfortable. I know I have a good, healthy baby. So this is a good strip to have. Okay, now in this part of the strip, let me get rid of all this so you don't get confused. We have variable decelerations. I gave you some minimal variability with these next changes, not because I want to stress our baby out. But because I want to show them more clearly. But sometimes when you have a lot of fluctuation, from the baseline, it's harder to see the changes. So here we have a strip with minimal variability, which again, we're concerned, but if baby's sleeping, that's fine. And we have what are known as variable decelerations. And I'm going to point to them right here. Okay, the key to a variable deceleration is that they have an abrupt descent from the baseline. They are from cord compression. Okay? It's a quirk in cord physiology. I'm not going to explain it, but it has to do with the fact that you have 3 vessels, and as one gets compressed, the heart rate sometimes speeds up, but you get that decel, and then as the cord compression releases, you get that shoulder. Sometimes you'll have shoulders on both sides, but anyway, it doesn't matter. A variable decel is from cord compression, and it looks like a V, a U, or a W. So we're going to make V, let's see. We're going to think about cord compression for variables, okay? Now, it's kind of unfortunate that variability and variables have the same name, but don't get confused. A variable deceleration is from cord compression. And it's not the end of the world. Sometimes it's just, oops, my baby found his cord, and then they let go, and they recover. A lot of times you'll see this with moderate variability. It's occasional. It doesn't mean anything. We don't want repetitive variable decels that go way down for a way long time. But an occasional variable isn't necessarily a cause for a major concern. It is just a symptom of cord compression. Definitely we'll want to watch it, and we'll want to watch for other signs that the strip is deteriorating, but that is what your variable deceleration looks like. And I'm going to try and sort of make another variable on the strip so that you can see they sometimes look like a check mark. They can have these shoulders, or they can look like a U, or they can look like a W. Those are all sort of things that the variable can look like. But the big tip off to that is that it's an abrupt descent from the baseline. You are not going to have this gradual slowing down. You cannot still call it a variable. But that is what a variable deceleration is. Okay, and next we have earlies. Okay, early decelerations. They aren't a bad thing at all. Hold on, let me get that fixed. They mean head compressions, and I'll explain the pathophysiology behind that. Just give me 1 second. Early decelerations, okay, let me show you what happens. They mirror the contraction exactly. So the beginning of the decel, sorry for my finger being so wobbly, they are like an exact mirror image. They start when the contraction starts, they end when the contraction ends, they get to their lowest point when the contraction is at its greatest point. And the reason for this is head compression. It's a vagal response to the head being squeezed. It's just like the baby Brady's a little with that head compression. The vagus nerve is stimulated. So what this means, it's kind of exciting when you're a labor nurse. If you've been laboring a patient all day and you start to see some earlies, you know that maybe the head is down further in the pelvis. Maybe you're making good labor progress. Sometimes you'll go and check a patient who has these earlies. If they had a good epidural and they're not complaining of anything, they'll just say, yeah, I feel a little more pressure, and you check and the baby's head is right there. That is an early deceleration. The only time that an early deceleration is really a problem, it's really not a problem for the baby per se, but if mom is really like 2 to 3 centimeters and the baby's head is way up high, the presenting part is high, and you're getting head compression, well, that might just mean that there's a tight fit, that pelvis isn't big enough. So the baby's head's getting squeezed before it's really descended into the birth canal. That would be a bad sign in that sense, but it's not a sign that the baby's in any kind of trouble in itself. Again, I've left you some minimal variability there. We're going to say the baby's sleeping, only because I want you to see the periodic and episodic changes a little bit more clearly. If I have moderate variability in there, it's going to be a little bit tougher to see. So we'll just kind of go from there. Okay, so next we get to talk about late decelerations, and I hate lates. Most of the time you won't see them with moderate variability. They are a sign of uteroplacental insufficiency, and they are bad. They are all bad. Now, usually you can fix them, so you don't necessarily have to panic, but I want you to notice something. These are very, very subtle lates. Let me put a pointer on them. See, right there. That's a late deceleration. They don't go very far from the baseline. So don't be fooled into thinking that the baby's heart rate's in the 80s, we've got to do something, but it's only 130 here, so we don't. It's really, you're looking more at the pattern, and I'll explain how you know that it's a late. Okay, so we said that an early started when the contraction started and ended when the contraction ended. So what we're looking at is a gradual descent from the baseline. It is not an abrupt descent like a variable. And when we draw that line straight down, I know that wasn't necessarily the straightest, we see that the deceleration begins somewhere in the middle of that contraction. Often it will begin at the peak, okay? And it can resolve either during the contraction or when the contraction ends. Sometimes it takes a really long time for that baby to recover. But that is how you know it's late. The contraction has a gradual descent down to the bottom. Okay. Oops, sorry. I'm still writing in black. That's not going to help you. Descent from the baseline to what they call the nadir. or nadir, the nadir, which is its lowest point, okay? So there's a gradual descent from the baseline to the nadir, okay? It is not that abrupt descent that you get with a variable deceleration. And sometimes people are real reluctant because they know that lates are an ominous sign. They will call something a variable when it's really a late, and we can all look at it and agree that it's a late. But they'll call it a variable with a late component. The new NICHD terminology really did away with that. You have to make a call. It's one or the other. And if you have a gradual descent from the baseline, and it begins, it's related to a contraction, it begins somewhere in the middle of that contraction, that is a late deceleration, and you need to know that that is a sign that the baby is not getting oxygen. Very often accompanied by minimal or absent variability. This is one that you want to resuscitate, okay? Sometimes you'll see this pattern. Patient has an epidural and their blood pressure drops. Remember that I said that back when we were talking about maternal trauma, and I said, well, eventually you're going to want to get fetal hearts because you know what? They're sometimes the most sensitive indicator of what's going on with mom. The baby will show signs of stress. So when mom gets an epidural and her blood pressure drops, before she gets symptomatic, baby gets symptomatic. And they might start running late. And then the cure for that, you'd bolus them with some fluid and maybe get some ephedrine on board, and then you fix them. But if this is happening and it's just in response to a normal labor, that can be pretty concerning because this is a baby that's not going to tolerate the normal stresses of labor. So that is a late deceleration. I just want you to note too that they can be subtle, they do not have to be dramatic, and they are worse than a more dramatic, say, variable or early deceleration. So don't get trapped in those what were the numbers kind of game. It is really the pattern that you're looking at. And you interpret it also within the context of the variability. And I would say this strip would have me very concerned. Okay, and the last type of deceleration that we're going to look at is called a prolonged deceleration. And this is a deceleration that lasts longer than 120 seconds. Again, these can be dramatic or they can be subtle. They can be a 10-beat change or they can be a 50-beat change. And in this case, usually the lower they go, the more dramatically we respond to it. But a prolonged deceleration, we don't have like a clear-cut cause for them, but certainly we want to resuscitate and get this baby's baseline back to normal. Now, if a deceleration lasts longer than 120 seconds, it's still a deceleration, but if it lasts longer than 10 minutes, it is now a change in baseline. It is now called fetal bradycardia. And if you have that pattern, that's certainly something. It's persisted long enough that now you're calling it a bradycardia. Let me see if I can find that up here. Okay, so I didn't find a strip that had bradycardia, but if you had a fetal heart rate longer than 10 minutes, that was less than 110 beats per minute, that would be a bradycardic strip. And unless you have some reason for that, if that's where that baby has lived forever, I know of one case, and it made us very uncomfortable. Somebody who was a Suboxone user. She had been on heroin and she was using Suboxone as maintenance, and her baby had a heart rate that was about 100 beats per minute, and that was just the baby's baseline. It made us all very nervous. And that was sort of one of those cases where you put a pulse ox on mom and showed her, it showed on the strip that you had two heart rates because mom's heart rate was very similar. So that's fetal bradycardia. Fetal tachycardia, I don't have a picture of that either. But fetal tachycardia would be, again, over 160 beats per minute at the baseline, and causes for that most often are maternal temperature. Sometimes maternal medications will cause fetal tachycardia. I know when we gave terbutaline, we always had to measure the baby's heart rate, and if the baby was tachy, we couldn't give it because it was a side effect. Mom and baby both had like an increase in heart rate. So that is the basics of reading a strip. I'm going to give you a mnemonic in just a minute. Okay, so to recap it, that was an awful lot of information. But if you want to know what the different changes in the strip are, I'll give you a little mnemonic to remember it. So we have veal chop. And I'm going to show you. We're going to do this. The V goes to the C. Okay, and that means variable. A variable decel is from cord compression. It also looks like a V, which helps. Okay, so there's our first part. Okay, the E is an early, and it goes with head compression. Okay, so remember, it's that vagal response. Okay, now we have A. A is acceleration. Goes with the O. And that is for oxygen. So acceleration means the baby is oxygenated. See how this is working? It's just perfect. Okay. And then our last one is L, lates. And lates are from placental insufficiency. Okay? Okay, so that's a really good mnemonic. So now we want to know, what do we do when we see something in a strip that we don't like? Maybe we have minimal variability, maybe we have lates, maybe we have repetitive variables that are not recovering well. So we want to know what we need to do about that. Hold on, let me get rid of this. So this is the part where we learn about intrauterine resuscitation. I know I referred to it before, and basically what we are doing with intrauterine resuscitation is we are maximizing the amount of oxygenation or well oxygenated blood flow to the baby while minimizing the stress that's causing whatever's making this strip look so ugly. Okay, so I'm going to give you another mnemonic, and this time it's called flop. So we have veal chop, now we have flop. Okay. And what it stands for is fluid bolus. Mom has extra circulating volume. What's the purpose of that? Well, the more volume there is, the more it's getting to the baby. How does the blood flow go through the baby? You have a placental, you have two arteries in one vein. The umbilical vein is how it goes through. And remember, we have to have an awful lot of circulating volume. It goes up by 45 to 50% on its own, nearing term. So we're going to mimic that response with at least 500 mLs of a, it could be normal saline, it could be lactated Ringer's. But we're going to give something, we're not going to do anything with dextrose. Dextrose will stress out the baby more. The baby will have to create insulin. So we'll say normal saline or LR, okay? That's our first intervention. That is our fluid bolus, okay? And usually when we're hanging, when we're starting an IV, or even if we have a half block, we usually have a bag of LR in the room just in case we need it. And there is, where I work, at least a standing order for this fluid bolus. It has to be at least 500 mLs to be effective. And you're going to give that at the highest rate you can. Just be careful when you're... one of the reasons we like this on a pump, I know some places still do it to gravity, is that it's pretty easy to tell which one is your LR, and you can open that wide. If you're hanging that and Pitocin, you certainly don't want to open your Pitocin by accident, and that has happened in the past. So make sure your bags are well labeled and make sure you're paying attention when you do this. So that's F for fluid bolus. L stands for lateral positioning. And I know every book loves to tell you that the left lateral position is the most important because, and there's a reason for it, when you put somebody in the left lateral position, that left ventricle doesn't have to pump as hard to get the blood out of the ventricle. So you increase your cardiac output without increasing your cardiac workload, just by simple sort of gravity. However, there's more than one variable. Some babies like the left lateral position. Some babies have their cord tucked in on the left side, and so you put them in the left lateral, they sit on their cord, they have a big whopping variable on top of whatever it was that brought you in that room in the first place. So then you might have to shift them to their right. If they don't recover fast enough, it might be hands and knees. But your first intervention is going to be lateral positioning, okay? If you see it on ATI, it might be left lateral because, you know, that's the textbook intervention. I just know some babies hate the left lateral position, and then you switch them to their right, and they're just hunky-dory fine. Okay, so that's lateral positioning. The O stands for oxygen. Sorry. And we're going to give oxygen at 10 liters per minute via face mask. Actually, I'm going to change that. It's rebreather mask. And that is really a better way to go. You can deliver 95 to 100% oxygen through this mask. We do this fairly freely in labor and delivery. We don't worry about oxygen toxicity as much with mom, but we are still kind of cautious. So you don't really do it until you've done the other stuff, and make sure that you educate mom why you're doing it without getting her panicked. I always tell them, listen, this smells like a shower curtain. It gives a little bit of extra air to your baby, but I don't communicate panic because that just makes things worse. Okay, so that's your oxygen, 10 liters per minute. That's your O. P stands for Pitocin off. And here's the thing. Labor is a stress. Contractions cause compression of those vessels in the placenta. Most babies are built for that stress. However, if we're hyperstimming this mom, or if this baby just can't tolerate labor, we're going to stop whatever it is we're doing that's causing this baby stress. We're not going to squeeze this baby's lungs anymore. Baby's not using their lungs for breathing. They're using their placenta for gas exchange. And so my suggestion is that maybe we want to change the order in which we do this stuff. Okay, and in fact, you know what? I'm going to do Pitocin off first. Then, turn mom to her side. I get that fluid bolus started, but it's going to take a while to work. I put the oxygen on. And sometimes just as soon as you turn that pit off and turn the mom over, you'll get a spontaneous recovery, or at least you'll start feeling a little bit better about things. But if you need that oxygen, put it on. Because, the baby's always a little less oxygenated than mom is. So if we hyperoxygenate mom, we'll get baby just a little bit more reserve. So that's intrauterine resuscitation. Now, you notice I have the pit off. When we get to labor, we're going to talk about how we manage Pitocin. Now, if you were using Pitocin because your labor wasn't adequate, you have to wonder what's going to happen. When you turn the pit off and you don't have adequate labor, mom can't make progress, the baby can't tolerate labor. Maybe we can get the baby to recover, and maybe we can't. So this is something you want to give SBAR on to your provider. Another thing you might want to know, it's not part of your mnemonic, but a vaginal exam sometimes will help you before you call the provider. If it's part of your practice. Some some facilities really don't want the staff nurses doing the vag exams, mostly because they have residents and the residents need to learn. Sometimes it's because a provider really just doesn't like to give up that vag exam. They like to do it themselves. If they like that, though, they really should be in-house. If you check the mom, sometimes, maybe the strip looks bad because the baby is having a rapid descent, and maybe you're going to have a delivery. Maybe there's a cord that's presenting that you can't see outside the vagina. So doing a vaginal exam is not a terrible idea after you've done all of the other resuscitation methods. And you can do a vag exam while mom is in the lateral position, but sometimes if the baby will tolerate it, you can turn her back to like a semi-Fowler's and try it that way just real quick to get your vag exam in. But like I said, you might be looking at a cord prolapse, you might be looking at labor progress. On the other hand, if you've been running PIT for 6 hours and mom is still 2 to 3, that's something that the provider should know. That if you're doing all this resuscitation and baby's not tolerating labor and mom's not making progress, you're going to need to let your provider know that as well. But that's basically fetal monitoring and then intrauterine resuscitation, what we do about it. And I'll repeat the intrauterine resuscitation content as we go along. You'll get lots of review on that. And as we do intrapartum nursing, we'll throw in some strips and we'll work with this and play with it in class. But that is about as much as you need to know about fetal monitoring for now.